objectives are to interpret and treat causes of bleeding in each trimester, to differentiate between placenta previa and abruptio placentae, categorize abnormal placenta implantation and the implications for hemorrhage, analyze a fetal monitor strip to determine uterine rupture, and design an emergency treatment plan for shock and DIC. So bleeding in pregnancy, it complicates about 20% of pregnancies, is one of the leading causes of maternal death in the US, and the incidence and cause varies by trimester. So in a first trimester, it might be because of a miscarriage or an ectopic pregnancy, whereas second and third trimester, it might be because of congenital anomalies or disruption of where the placenta is implanted. Some of the effects of blood loss for the mother include an increased risk of hypovolemia, anemia, infection, preterm labor, and birth. And then for the fetus, the risk is directly related to the amount of blood loss and how long the mom is losing blood. So due to the small blood volume of the fetus, even a little bit of blood loss in the fetus can be life-threatening. Maternal fetal gas exchange decreases. There's a decrease in blood flow to the placenta, which can cause hypoxemia, hypoxia, asphyxia, and death. Causes of bleeding in pregnancy are typically either placenta-related or uterine-related. So for the placenta, we'll discuss placenta previa, placenta accreta, abruptio placentae, vasa previa, and for uterine, uterine rupture, and uterine inversion. So placenta previa, the implantation of the placenta in the lower uterine segment over the cervical os. So we have some different examples here. You have a low-lying placenta, which is next to the cervical os, which is right here. You have a partial previa, which partially covers the cervical os, and then a complete previa would cover it completely. A low-lying placenta, if prior to 30 weeks, it usually resolves itself. This is something that is usually identified through ultrasound. Here's another picture of the different types. You have a marginal previa as well, which is like right at the tippy top of the cervical os. Factors associated with it, increased parity, and do we remember what parity means from yesterday? Yes, I'm like, you said it yesterday. Number of deliveries, multiple gestation, prior placenta previa. So again, if you had it in one pregnancy, you can have it again. Uterine scarring, which can usually occur because of C-section, fibroid removal, or DNC. And then an advanced maternal age, which is 35 years or plus age, and a larger placenta, and smoking cigarettes. So how does the patient present? They have painless vaginal bleeding, intermittent with continuous bright red, or with or without clots. So when you see that hint, remember my hints from yesterday? Painless vaginal bleeding, diagnosed by ultrasound, usually means placenta previa. It's most often diagnosed before the bleeding occurs. So the accuracy of diagnosis is 93 to 98% per the ultrasound. And if you already know it, then you can get a handle on it and figure out what to do as far as delivery options. When you have a complete previa, like the picture that I showed where it's covering completely, you're not delivering vaginally. You're going to get a C-section. So like I said earlier, if it's a low-lying placenta where it's kind of like next to it, that usually resolves on its own. You don't really have to worry about that. But hint, if it's complete, you're going to have a C-section. So the management is based on gestational age, the amount of bleeding, the uterine activity, fetal response, and bed rest might be a treatment. So a person can come in for vaginal bleeding, but as long as their abdomen is soft, they're not contracting, the fetus looks fine, we might kind of just wait and watch. See exactly where the bleeding is coming from. If we can detect where it's coming from, if it seems like it's slowing down, we'll figure all of that out before we try any interventions. We try to decrease the amount of cervical exams. We want to monitor the amount of blood loss using a pad count. And for acute bleeding, we want to obtain IV access, monitor the blood pressure and the pulse regularly. We want a type and cross on file. We want a complete blood count on file as well. We also want a coagulation profile every 6 to 10 hours, and we want to continuously monitor the fetus. If the mom is hemodynamically unstable or fetal distress is unresponsive to the interventions that we try, then we want to deliver the baby as soon as possible. But if responsive and the bleeding stops, you can continue hospitalization, or if everything is okay, as long as mom has somebody to support her when she goes home, she can go home and continue bed rest there. It really depends. So for our care, nursing care, we want to have the mom do bed rest, probably with like bathroom privileges. You want to check pads, count pads, assess fetal well-being using NST or BPP or continuous fetal monitoring. It really depends if the mom is continuously bleeding or not. And again, yeah, we want to maintain fetal monitoring if there's an episode of actual bleeding. We want to maintain IV access, and we want to keep a type and cross match current. So for mainline health, if we have someone here who's here for an extended period of time, every 3 days, we need to have a new type and cross on file. So review, there's 4 types of placenta previa. You have a low-lying placenta, partial, marginal, complete, and it presents with painless, bright red bleeding, a soft abdomen, and is diagnosed by ultrasound. A vasa previa, vasa means vessel, previa means covering or crossing the cervix. It results from the insertion of the cord. It doesn't insert into the middle of the placenta the way it's supposed to, but instead it implants into the membranes instead of the placenta. And what also happens is the Wharton's jelly that covers the cord is missing, as we can see. So what happens is the cord can easily be lacerated or cut, which would cause bleeding in our baby, which is not good. So diagnosis and management, sudden appearance of bright red blood at the time of membrane rupture and fetal heart rate deterioration. So honestly, when you think about if a doctor artificially ruptures someone's membranes, there's bloody show, you're gonna see different things down there, but if they rupture and all you see is straight blood, no watery fluid, that's your hint that this might be something bad. This is something bad. So an immediate C-section is usually the treatment of care. Fetal blood loss is rapid. Total fetal volume is 80 to 100 milliliters per kilogram. And the survival rate, if it's diagnosed before, then 97%. That way they already know, we'll just do a scheduled C-section, we'll call it a day. But it's undiagnosed 56% of the time. So it's something that we have to be careful about and look for. So the umbilical cord is implanted into the fetal membranes rather than the placenta. There's an absence of Wharton's jelly, which makes the cord easily susceptible to laceration. Sudden appearance of bright red blood at the time of membrane rupture and fetal heart deterioration is present. And a planned C-section is the best way to treat this. An abruptio placentae, this is an unpredictable premature separation of a normally implanted placenta. So it's diagnosed based on the amount of separation. It accounts for 15% of neonatal deaths, and it is the leading cause of perinatal mortality. The exact cause of why the placenta decides to separate itself is unknown. But there's 2 different classes. So it's revealed or concealed. And when it's revealed, you can see vaginal bleeding present. But when it's concealed, there's a separation occurring, but there's a collection of blood that we cannot see. And with the concealed, there's an increased chance of DIC. And here's a picture. So with the revealed, you see how there's an opening, there's a bleeding occurring, and we can see that come out through the vagina. But with concealed, the detachment is happening, but we're not able to see exactly that the bleeding is occurring. Factors associated with abruptio placentae is a previous abruption, hypertension, PPROM, prior C-section, and choreo. All things we talked about earlier. Any questions? Multiparity, cocaine use, smoking, short umbilical cord, blood abdominal trauma, and thrombophilia in pregnancy. So how it presents, it's a sudden onset, it's intense localized pain and tenderness at the abruption site. So again, it can be with or without vaginal bleeding, so that would be revealed versus concealed. Preterm contractions with vaginal bleeding. The contractions are low amplitude, high frequency, increase in uterine resting tone, so we have to palpate the abdomen to feel exactly what these contractions feel like. If somebody is having super strong contractions that are not letting up, that's a problem. The fetal response, it depends on the blood loss, the amount of blood loss. So the extent of uteroplacenta insufficiency. If it's like completely separate, you're going to see a decline in your fetal heart rate immediately. But sometimes the fetal heart rate might actually be okay because it hasn't detached that much. So bradycardia, tachycardia, late B cells, and minimal variability are the things that you would see. Diagnosis is based on patient's history and physical exam, uterine tenderness and rigidity. Ultrasound can exclude placenta previa as a cause, but it can't diagnose an abruption. So it's really kind of, you have to figure it out yourself. That's where your critical thinking skills come in. That KB test that we talked about yesterday, HINT, that is something that we want to use in order to test for the presence of fetal red blood cells in maternal blood. If they're mixing, you'll use that test to see how much fetal blood is being lost. So the management of it, if it's unstable, just go ahead for an emergency C-section. Again, you're gonna see on your strip that your baby is starting to deteriorate. So there will be fetal compromise, severe hemorrhage, coagulopathy, increasing uterine tone, and poor labor progress. In a stable situation, meaning that the fetal heart rate tracing is reassuring, or unfortunately your baby's already dead, so mom is stable, obviously baby's not, you can attempt a vaginal birth. So review, again, an abruptio placentae is an unpredictable premature separation of normally implanted placenta. Revealed is when vaginal bleeding is present. Concealed and when there is no vaginal bleeding present and it has an increased chance of DIC. The KB test tests for the presence of fetal red blood cells in maternal blood. And vaginal birth is stable. So, the next thing we'll discuss is the placenta accreta. So all or part of the placenta attaches to the muscle layer of the uterus. The incidence of placenta accreta increases when women have had a previous surgery, such as a C-section. Placenta accreta happens in 80% of cases of these accreta type conditions. An increta is when the placenta invades the uterine wall and penetrates into the uterine muscle, and that happens in 15% of cases. A percreta is when the placenta penetrates the muscle layer through the serosa and develops on organisms in the vicinity, such as the bladder. And that happens in about 5% of cases. So you can see the difference in the picture. The accreta attaches, the increta invades, and the percreta penetrates. And that's how you can remember it. Accreta attaches, increta invades, and percreta penetrates. It can be diagnosed before birth by ultrasound in the first or second trimester. The goal is to prevent shock, thrombosis, infection, and acute respiratory distress syndrome. We recommend that you have packed red blood cells available in this type of situation. And planning and team members are important. So anesthesia needs to be on board. Surgery, urology, again, it's trying, in the percreta situation, it's trying to attach to nearby organs, such as your bladder. So you wanna have them involved. Interventional radiology, just in case of an embolization. Uterine rupture. So there's a tear in the uterine wall. And it occurs when there's been a previously scarred uterus based on like a uterine surgery, such as a C-section. So that's something that we look for when we have patients coming in for VBAC. We wanna make sure that we go really slow with helping them if they have to be induced or if they have to be on Pitocin. We don't wanna hyperstimulate them because they can rip that incision that was previously there and rupture their uterus. So the causes are hyperstimulation by oxytocin or prostaglandin administration, bundle pressure, which we said we're not gonna do ever, right? blunt trauma, such as a motor vehicle accident, fall, gunshot wound, knife wound, and it could just completely be spontaneous. Signs and symptoms, they may occur over several hours or minutes, but your patient will complain of abdominal pain, tenderness, sharp tearing, tearing pain, vomiting, syncope, vaginal bleeding, tachycardia, pallor. Uterine contractions may or may not be present or a decrease in uterine tone. And the presenting part will not be reachable. So when the doctor goes in to do a vaginal exam, they won't feel anything because basically your uterus is ripping and your baby is like floating around. Diagnosis is suspicion. Placental abruption will usually occur at the same time. And the treatment is maternal stabilization and immediate C-section. In most cases, hysterectomy occurs in these cases. So this is a picture of what it looks like when a uterus ruptures. Like I said, your baby's kind of floating around out there. And this is what your strip would look like. So the bottom of your fetal monitor strip is where you see your contractions, and it's one contraction on top of another. It's not really letting up. So what would you see on your strip? You would see a decrease in variability, recurrent variable, prolonged, or late decelerations followed by bradycardia. So you'll start to see your strip kind of dip down, go back, dip down, go back, and then all of a sudden it's just going down. Any questions so far? Okay. Uterine inversion is basically when your uterus turns inside out. The risks are long labor, previous inversion, fundal pressure, which we said we're never going to do, right? And traction on the cord. So if you can think about when the patient delivers, and now they're trying to deliver the placenta, do you ever see the doctors kind of like tug on the cord a little bit? They do it slowly. They don't do it too hard, because if they do, this could happen. The management is emergent. Severe hemorrhage can occur, so IV fluids, blood, and antibiotics need to be on board. And the treatment is to attempt to replace the uterus either manually by the doctor, kind of just put it back, or balloon pressure such as our Bacry balloons, or surgery. So you might be running back to the OR in this situation. For postpartum bleeding, which I know pertains to most of you guys, it's the most serious type of hemorrhage, and it happens usually because of uterine atony after placental separation. So while I know some of our campuses are LGRP and then others are split, so for Lankenau, while our patients are with us back in labor and delivery, we're constantly checking in that first hour every 15 minutes to make sure that the uterus is nice and firm, nice and contracted. And then what else do we do to keep the uterus contracted? Say it now. Pitocin, yes. So we do a low dose of Pitocin, 20 in a 1,000 milliliter bag of fluid. So we try to do that. If not, we break out the black box and we use different medications in there to try to help firm up the uterus before we send them to postpartum. Other causes are retained placenta products, uterine rupture, uterine inversion, genital tract trauma. So it might be just a bleeding that's occurring in the vaginal or cervical wall. And also coagulopathy. So if we remember yesterday, we talked about how everything kind of goes up, all the red blood cells, all types of blood cells go up, and so now moms are more prone to clotting. So our complications then are shock and DIC. So with shock, it's a sudden decrease in blood flow to the body. Due to hemodynamic changes of pregnancy, remember, everything is going up. A pregnant woman can lose up to 30% of their volume before you even see signs and symptoms of shock. So that's an important hint to know. The signs and symptoms include an increased thready pulse, pallor and clammy skin, decreased blood pressure, and hyperventilation. The fetal heart rate changes that can occur with shock are loss in variability, initial compensation, which will be tachycardia, and then sudden bradycardia. A sinusoidal pattern, which kind of looks up and down like this, with persistent late decelerations, or an absence of a fetal heart rate. In DIC, it's a massive activation of a clot clotting cascade. So basically, mom's bleeding, the platelets are kicking in, that's being depleted, and what's happening is there's too much clotting and not enough clotting all at the same time. Some of the factors associated with DIC are abruptio placentae, hemorrhage, preeclampsia, amniotic fluid embolism, sepsis, retained dead fetus, cardiopulmonary arrest, and massive transfusion therapy. So what do our labs look like when we have DIC? Platelets decrease, fibrinogen decreases, PT and PTT is prolonged. The D-dimer, which would normally be negative, is now positive because of the high fibrin. Mortality rate is 50 to 70%, and the cause of death is usually because of end organ damage. So we treat it by, number one, consulting with maternal fetal medicine doctors at our places of employment. And it's recommended that we start to treat it as soon as it's suspected. So blood products is what we need on board. Our point is to stabilize the mom, deliver the baby, and then get the vital signs in order. So when we document, we want to make sure that we have the delivery time, the time the bleeding has first been identified, the estimated blood loss, who was there, the interventions, the response, periodic reassessment, surgical interventions, and anything else that pertains to the patient. INOs, patient condition, ongoing management plan. So, one more thing before I review that, we have to make sure that we have blood products on board. So when we talked about an OB stat earlier, you're gonna call your blood bank and they're just gonna start preparing things for you, and they're gonna keep preparing it, but you have to call them back to let them know when to stop. That's the one thing we didn't talk about a little bit earlier. So they're gonna keep preparing blood products until you call them back and say, okay, we're done, don't prepare anymore. So again, in review, shock is a sudden decrease in blood flow to the body, loss in variability. It initially compensates with tachy and then subsequent brady. For the fetal heart rate, you'll see a sinusoidal pattern with persistent late decelerations or an absence of fetal heart rate. And then for DIC, bleeding occurs, platelets and coagulation factors are depleted, and bleeding continues with a lack of those factors, and so you need to replace those factors with blood. So blood and volume replacement, again, OB stat protocol, we call the blood bank, notify them, and they will have prepared for us 4 packed red blood cells, 4 thawed plasma, 1 single donor platelet available at all times until canceled by the labor and delivery staff. Blood loss is often underestimated, and so follow-up labs will be drawn. We have to be cautious with rapid infusion of these products because we don't want to flood out their lungs and give them pulmonary edema as well. Some of the products that we replace with are fresh whole blood cells, red blood cells, platelets, fresh frozen plasma, and cryo. And that's that. So let's do a Kahoot like we did yesterday. Yay. This one's a little shorter than the one yesterday. You guys know to go to kahoot.it. And this is your game pin. I just have 9. Yep, all right, let's get started. of which placenta previa would a C-section be the only mode of delivery? Yay! Good job, Alexis. All right. At the time of rupture of membrane, bright red blood is present, indicating the following condition. Right. So let's, that's vasa previa. So when we remember that, number one, that Wharton's jelly is missing, so the cord is easily able to be lacerated, and also it's covering the cervical os. And when they go to rupture the membranes, you will see bright red blood with vasa previa. All right. Which lab result for a patient with sudden onset bleeding and localized pain requires nursing action? We talked a little bit about D-dimer when we talked about shock, and we said how it would be positive instead of negative. But the one that we really want to look for is that KB test, because it will let us know if there's any fetal blood mixing with mom's blood, okay? All right, ultrasound testing reveals the placenta invading the uterine wall. Select the correct condition. All right, invade, increta. Okay, attach, accreta. Precreta. What else? That penetrate, thank you. All right, prior to showing signs and symptoms of shock, you determine a pregnant patient can lose what percentage of blood? Yay, 30%. So remember, everything is revved up, so we can lose a lot before we actually show signs and symptoms. And our last question. A laboring patient on PIC complains of sharp pain described as tearing. What does the RN suspect? That's our strip